Good morning, PT on Ice, Institute of Clinical Excellence. My name is Dustin Jones. I am one of two faculty members with the older adult division, me and Christina Previtt. Hopefully y'all know us by now. We teach modern management of the older adult, an 8-week online course. We just finished week 4 of our second cohort last night, had an awesome discussion that's going to drive the PT on Ice today. So we're going to talk about sexiness and significance. Since we're on the topic of sexy, we should mention a few courses that are coming up. Eric Chaconis is in Sioux City, Iowa for the extremity course, April 28th, so that's this weekend. Jeff Moore is going to be in Santa Barbara, California for the lumbar course, May 12th. And then May 19th, we got a busy weekend with Jessica Davis in Winston-Salem for the cervical course. And then Jason London is in Blacksburg, Virginia for the injured runner course. So that's what's coming down the pike. But today's episode is going to be on sexiness versus significance. I want to share a story. This is a patient that I saw just yesterday. It was a discharge visit. So this is a woman that was probably min assist to mod assist for bed mobility transfers, needed assistance with walking. This was, I think, probably 3 months ago is when I started seeing her in home health. We kind of went through the gamut, progressive resistance exercise, addressed a lot of the fear of falling that she had, modified a little bit of her environment. We were making some amazing gains. I mean, we're talking big jumps in functional outcome measures like her timed up and go, the Berg balance score, the SPPB, some of those different measures that we like to use. Doing awesome. She kind of reached a plateau. She has a really good caregiver, and they were, doing pretty well with the home exercise program. So at that point, okay, you do your thing, keep going. If you need me, call me, but you're good to go. So it was our discharge visit. I walk in, and she is just shaking and having a lot of trouble getting out of the chair. She actually needed, my help to get out of a chair, which is the first time in a couple months that she's actually needed assistance. Good morning, Will. And just real shaky. She was, had that kind of posterior sway, a lot of stiffening strategies, very unstable, very uncharacteristic from what I was used to working with this patient. I mean, she's been having these consistent functional gains, improving, things were going great. And then I come in yesterday and it was like we were back at day one. So this is a discharge visit. So I'm going to go through a lot of these functional outcome measures that we typically do so I can, gauge the progress and be able to show how, we've been able to work together to improve the situation. And all of her measures were the same as baseline. So her functional trajectory, say this is baseline. We did awesome, we did awesome, we did awesome. And then yesterday, boom, back to baseline. So I'm like, what in the world is going on? What happened within the past 4 days since I've seen this person that has caused such a sharp functional decline? So almost always, I'm immediately going to, double check their vitals. All of that was normal. And then at that moment, the caregiver, the paid caregiver comes walking in and tells me the other caregiver that works with this patient stole that patient's Xanax. And that patient hasn't had a dose of Xanax in over 3 or 4 days. And this is a result of missing that medication. And my first thought was, really? Like Xanax can have that much of an impact on someone's life? So you're telling me that all that progressive resistance exercise that I did, all those things that we were working on and showing functional progress, all of it can be taken away in 3 days by them missing their dose of Xanax? Like, come on now, let's be serious. Because, you all may share some of the sentiment, but at least, around the Institute of Clinical Excellence, we tend to hate a lot on medications. We talk a lot about overprescription of pain meds. We talk about a lot of the medications that are used to kind of cover up some of these lifestyle diseases. And overall, I feel like we're not very pro-medication around here. But this is showing that medications can have a significant impact on a lot of people's lives in a lot of different situations. But I don't like medications. I don't like doing med reviews. I don't like educating my patients on when they need to take a certain pill and how often. Troy Mead's watching this. He's a home health clinician. It's a big deal in home health, but a lot of us just don't like it. It's not that exciting and it's not sexy. But here's the point of today's podcast. We cannot mistake a lack of sexiness with a lack of significance. Some things that we do with our patients are not going to be sexy. They're not going to be exciting. We could give two craps about whatever that intervention is or whatever we're talking about, but that may actually be very, very significant for our patient and actually getting them to improve. That's something that I need to hear a lot of, and I need to practice this and be reminded of it. I imagine many of you all listening need to be reminded of this as well. See, we are physical therapists. We serve people. A lot of times they're kind of in the driver's seat. We're trying to help them, improve upon their situation and reach their goals. So we don't need to be focusing on what is new, what is trendy, what is sexy, but what is actually significant for that person given their situation and given where they want to go. We need to put a premium on significance and not sexiness. But what do we see in the world of physical therapy? We see a lot of talk about the new techniques, the trendy technology, some of the different things that are very exciting, that we generate a lot of discussion on these platforms, on Facebook, on Twitter, on Instagram. But that may not necessarily be significant. There's lots of examples, but the one that I'm going to use is dry needling. Now, when I started using social media in a professional manner 3-4 years ago, the overwhelming majority of conversations were about dry needling. Now, I'm not here to say I'm pro dry needling or anti dry needling. I don't really care about that side of the equation. What I'm talking about is whenever I hopped online and started to observe our professional conversations with a lot of people that are higher up in our profession, the overwhelming majority of these conversations were revolving around dry needling. It was very sexy. It's very exciting. People were very passionate. People were going to go to the grave for their defense of dry needling. But when we zoom out and we take a bigger picture of the realm of physical therapy and improving well-being in our patients, how big of a role does dry needling play if we're going to be speaking in general terms? Not that much. I mean, yes, it's going to be a huge game changer for a lot of people, but overall, dry needling is a tool in our toolbox. It's a modality that we can use to potentially help people move the needle forward. It's really sexy. It's really exciting. We get to use needles. That's a lot of fun. But it may not necessarily be that significant in terms of the grand scheme of physical therapy. But if I were just to hop online and look at all these professional conversations, I thought this was going to save humanity. It was going to end suffering for everyone based on the percentage of the conversations that we were seeing. So I think that's one example that comes to mind for me whenever we confuse sexiness with significance. It's very easy to do, but we need to be able to tease those out. We can't necessarily make that correlation. We have to focus on significance. So this is the Older Adult Wednesday PT on Ice segment. So if we are going to apply this to older adults, what is significant for them, but not necessarily sexy? And so many of you all would argue that geriatrics in general isn't that sexy. We're trying to change that around here. Hopefully we're doing a good job, but there's a lot of things that whenever we're working with older adults that we have to consider, we have to do that is not exciting. It's not that interesting, even to me, the guy that's always preaching geriatrics. I don't love a lot of this stuff, but I know it matters to my patients, and I know it has an impact on their quality of life, so we need to be about it. So the first one, the one that I already talked about, is medications. If you are in the outpatient setting, you're likely not necessarily doing this, but I highly encourage you just to look at someone's medication list. Just see how many medications they're on. That number in and of itself is going to give you a good idea of the health of that patient, but then also if they may be at a potential fall risk. And you may be able to identify some medications that have been shown to not necessarily be that beneficial for older adults, or they have significant side effects that could impact their function. I'm going to post a link in the Facebook post, but there is a really good document called the Beers Criteria. So this is a list of medications. It can be kind of dense, but you can kind of get the general principles of it. But it's basically a list of potentially inappropriate medications that are used in older adults. So one of the most common ones that you're going to see are benzos. And Xanax that I mentioned before with my patient is a benzo. And if you listen to that story, that has such a big impact on her functional capacity. that one pill, that one stinking pill, she missed, a few days of that, and we're back to baseline. Like that's a big deal, and you can capture that, even in the outpatient setting. So look at medications. Do even if it's a super quick med review, that's going to be that's going to be better than nothing. So I highly encourage you to do that. But check the link for the Beers criteria in this Facebook post. So the second one, vital signs. So the hashtag vitals are vital. A lot of us, have heard that. But if you haven't searched that hashtag, I highly encourage you to do so. If you go through just that search, what you're going to find are several posts, especially on Twitter, of regular outpatient clinicians that got in the habit of taking blood pressure. And what did they find? They found that there were some people that were walking in their clinic with a systolic over 200 and a diastolic over 100. These are people they were functioning fine, they were doing okay, but cruising along at that blood pressure for a long period of time does not end well. A lot of things, a lot of complications can occur, but those physical therapists were able to capture that, were able to screen and be able to divert that person to say, hey, you don't need physical therapy right now. You need a beta blocker. You need to go to the emergency department and see a physician to help with that. So vitals are vital. I mean, don't ever assume that everything is going okay. We need to just do that quick assessment and be able to screen people and capture them if they are at high risk for, say, a cardiovascular event. Dr. Rich Severin, he's the one that's been really championed this message with several other people. But I'll put a link in the notes as well so you can track more of that. There's some good resources too from the APTA about how you can be more encompassing and monitoring and checking vitals, even if you're just a good old outpatient therapist. So the third one, it's not sexy at all, but it's pretty significant, and that is addressing incontinence. So the hashtag pants not pads. I'm really thankful for Sarah Haig and Sandy Hilton, Sean Hagee, some of these people that really talk about incontinence and bring light to this issue. I know, like, when I think about incontinence, before I was a home health clinician, I was like, oh, well, that stinks. If you, mess yourself every once in a while, or, you're just not able to control your BMs, just that can create kind of a mess. You don't necessarily think about what that actually means for someone's life. And now being kind of on the other side in home health, just the slightest bit of urinary incontinence, for example, I've had patients where it reduced their daily physical activity levels to, maybe 10% of what it was before, because they were so worried about, having an issue while they're ambulating around their home, or even preventing them from even going out in public. This has the urinary incontinence in terms of its sequela afterwards, in terms of how it impacts their interactions in the community, activity levels, all those different things. Confidence has such a massive impact on the quality of life of our patients that we need to be having these conversations and being able to address urinary incontinence or refer to a clinician that can do so. So brush up on that. Look at the hashtag pants not pads. I'll put a link to some of Sarah and Sandy's work from Entropy in New York. But it's really good stuff, and we need to have that on our radar because it's very significant for our patients. And lastly, this is my jam in home health, but home modifications. My goodness, I can take a piece of furniture and move it 6 inches to one side and significantly change someone's quality of life. I mean, how easy is that? It's amazing. But you can make home modifications or recommendations for patients that are going to make a big impact on how they move, on their activity levels, on their independence in their home, or even their ability to get out of their home safely. So home modifications is very, very, very helpful. I'm going to put a really helpful guide or a PDF in the Facebook post, so be sure to check that. So those are the 4 things I want you all to think about. They're not sexy, but they're super significant, and they're going to help your patients. Medications, vital signs, addressing incontinence, and then home modifications. So I want you to think, to wrap things up, with your patient that you see today, I want you to think to yourself, what can you do that's going to significantly improve their quality of life? Don't start at what is sexy, what is trendy, what's this new piece of equipment or this new technique or whatever it is that's exciting. Don't start there, but start with what would be significant. It may be something you learned back in PT school. It may be something that PTs have been doing for decades. But if it's significant for that patient at that moment, right then, right now, you need to do it for them, even if it's not considered sexy. So for my patient, what was significant for them? It wasn't progressive kettlebell goblet squats. It wasn't deadlifts. It wasn't loaded carries. It wasn't a lot of the things that we talk about on this podcast. It was picking up a phone and calling her power of attorney to see what's going on, talk to her, and then call the doctor to see if we can get a script filled for Xanax. That was the significant intervention. Not fun. I hate calling physicians. I always have to wait for 20 minutes, and then they take 4 hours to call me back. But it's significant, and we got to do it. We're able to move some furniture, do some home modifications. We finally got her to pick that freaking rug up in the hallway, which will significantly reduce her fall risk walking through there. So these are things that I don't enjoy doing them, but they're significant for our patient, and we need to be thinking about that. So if you want to learn about what is significant for your older adult patients, if you want to continue this conversation, I highly encourage you to join our course, Modern Management of the Older Adult. So the next cohort is going to be June 12th. Seats are already filling up, so I would go ahead, ask us any questions if you have any, but sign up. We'd love to have you. We have a lot of these conversations within that group about what matters, what matters for our patients, especially in particular the older adults. So all that stuff can be found at ptoниce.com. Check this post for the resources. And I think that's it. Appreciate y'all watching, and I will talk to y'all in a couple weeks.